much for coming. I want to welcome you to the AG's second report release for 2026. We have a few extra people in the room, so I'll just walk through that. We will have introductory statements from Auditor General Adair. Then we'll go to the room for all of your questions. And now, here is Auditor General Adair.
Okay, thank you, Amy, and good morning, everyone. So this morning, I filed a new report in the House of Assembly, an audit of the Action for Health Key Performance Indicators. The Nova Scotia government launched its Action for Health strategic plan 3 years ago to transform the provincial healthcare system. At the time, it committed to provide regular progress updates through Key Performance Indicators, or KPIs. Nova Scotia should be commended for initiating a program to report health system KPIs. The decision to report key performance indicators as part of the plan to build accountability at every level of the health system is a positive initiative for transparency and accountability. Healthcare spending makes up almost half of the province's total spending budget, about $7.4 billion. And spending for Action for Health in its first 4 years is anticipated to be nearly $1.3 billion. That's why we decided to take a look at a number of the KPIs. Our sample was selected to provide a cross-section of indicators that represent different aspects of the healthcare system, including those tracking the number of doctors, nurses, and continuing care assistants, and measuring access to primary, long-term, and home care. What we found is that reporting weaknesses affecting the 13 KPIs we examined make it challenging for Nova Scotians to understand the information about Action for Health and health system performance. Audit testing examined for the report revealed that most KPIs don't use effective targets to track performance against expectations. 2 of the KPIs were found to have significant data concerns. In addition to province-wide results, health zone and our facility level reporting is needed. So, while the province's decision to report KPIs is a positive initiative, the results of our audit reveal this program could be more effective with identified improvements. The audit includes 12 recommendations to improve reporting. However, the Department of Health and Wellness disagrees with 3 of the 12 recommendations, including transparent reporting on Nova Scotians seeking a primary care provider, providing facility or health zone breakdowns of health system performance, and reporting on those who leave the emergency departments without being seen. The audit also suggests reporting should be more comprehensive and cohesive, as information currently is on multiple public sites. Implementing these changes would help Nova Scotians better understand health system performance. Nova Scotian taxpayers deserve to know what their billion-plus investment under Action for Health is achieving. So I'd like to thank my staff for their work on this report and the departments and organizations that were involved for us to be able to produce the report today. So now I will open it up to take your questions.
Ms. Adair, if we could start with the Family Practice Registry, because the bulk of your report kind of focuses on, a lot of it anyway, focuses on that. And we had a bit of an update from the province yesterday. Just in terms of the reference to the province's update yesterday, we're being told we're going to get more metrics in a couple of months, although we haven't seen those yet, obviously. But they are clearly not going to move off this idea of removing the pending people from the overall tally of who's waiting to be placed. Why, in your estimation, is that a mistake?
All right, so I'll try to put it in context, and I guess, but the tail end of what you said, the fundamental difference in our position is that people on the pended portion of the registry, so people whose placement is in progress, in our view, are not yet attached. In our report, there's a really good section in our report on all of this, and a good chart on page 25 that explains what happened. In October of 2024, there was a major change in the way that they were calculating the KPI and the announced numbers of who was on the registry. They essentially moved a significant portion and put them on this pending status. It had a significant impact on that registry number and what was announced, and we show in the report how it significantly made the KPI appear better. But people that are pended, I would say, are in progress of being attached. So from what our understanding and our work shows, if you receive a letter that you maybe have a clinic for you to consider, there's many parts of the process that has to happen. For example, is the location of that clinic a fit for where you live, where you work, where your children go to school? And also, in some cases, the clinic may not be fully operational. It may not be open yet. We also looked at the documents and the templates of the letters of what people receive, and we noted that in that letter, they're instructed not to contact the clinic and wait for the clinic to contact them. So all of that to say, we were surprised that they consider them attached. We don't consider them as attached at that time. And in terms of where they're placed, what our recommendation is just include full details and explain the different categories. Very surprised that in October 2024 they didn't explain that at the time. But here we are today, and what's good and what's positive is that even though they disagreed with the recommendation in our report, what was announced yesterday, in fact, is essentially they're going to do what we had recommended. So it is good for Nova Scotians. Improved transparency will result. We'll be watching. It's happening in April, apparently, which is fairly quick compared to the timelines that they've indicated in a lot of our recommendations. So hopefully I've answered your question.
Yeah, and dovetailing on that, because that's gonna come with we're gonna go back to the days of information broken down by health zone and perhaps even health network, and that's another thing that you get into in this report, this idea that sure, there are some KPIs that you can break down by facility or zone, but there are others where you cannot, and you point out what that can do to kind of weigh an average one way or another. I'd just like to hear you, in your own words, talk a little bit about what you think is the significance of the public having access to KPIs beyond just a single provincial average.
So in our recommendation, we suggest, where possible, to break it down, in addition to the provincial cumulative number, include regional breakdown or health zone information. When it's all in one, it might mask what's happening in a health zone. So it's just improved transparency. It's unfortunate that they have disagreed with that recommendation.
Adair, what do you make of their explanation for why they disagreed with that particular recommendation? Did that hold weight to you?
So if you read the text attached to their response, I didn't find any of them overly persuasive as to their justification for not doing it. So I guess that's all I can say.
I wanted to also talk about the specific recommendation regarding people who've left DRs without being seen, and then this is one of the three that the department has disagreed with. Can you talk about why that's an important metric that's not being understood by people right now?
So we feel that those who leave without being seen is a good, I guess, companion indicator to go along with the emergency department wait times. We did find that the data that they do gather, especially in the central zone, is fairly robust. It was in the past reported publicly, and it was at one point required because there was legislation in place, but has since been repealed. Again, it would provide more transparency. We don't understand why they can't do it, at least for the central zone. And it's interesting that our recommendation to improve the data collection on that very issue they do agree to do. So they're gonna improve the data collection, so they'll be in a better position to actually provide that information.
So Adair, does that figure count people who who have at least registered with a nurse? Like, I'm thinking about people who might walk in, see a whole bunch of people waiting, and just turn around and walk out. It wouldn't count that person.
So to answer that specific question, I would have to check with the team. Oh, I'm getting it, no, it does not include those people.
Okay.
Okay.
Yeah, I think part of the province's defense or justification had to do with rural emergencies. The
Yeah.
Royal Emergency Departments, and virtual care isn't counted. That was another thing the province said. But you clearly weren't persuaded that it couldn't be done.
Correct.
Can I just ask, so when a Nova Scotia goes on the dashboard now and looks at the needed family practice registry, it says there's 66,000 people waiting.
Mhm.
In your view, there's a big asterisk next to that number.
Yes, because that would not include the people that are pended or in progress. And in our view, they're not yet attached, so they should be publicly reported. I mean, you can show the different categories, and that's essentially what we've recommended. Yeah, just need to give the full picture.
And when do you consider patients to be attached? Is that that first appointment, if it's not in that sort of limbo time?
I believe there's an indication in the system that they've had their first appointment, and you can see it through the billing of the physician.
Ms. Adair, you mentioned that 3 performance indicators had inconsistencies between what is measured and what the key performance indicator was intended to report on. Off the top of your head, do you remember which 3 those are?
The inconsistencies, well, so with respect to targets, our overall finding is that either there was no target or the target that was there is ineffective to measure what the KPI is intended to measure. There's a lot of detail in the report, but just off the top of my head, so for example, healthcare providers, whether you're measuring additional physicians in the system, nurses, or community care assistants, the chart shows that those numbers are increasing, but there's no target. So you don't know, are they achieving what they intended to? Is the 1.3 billion that has been spent on this initiative, you need to know whether they're meeting the target that they intended in order to assess performance.
Value for money, essentially.
Correct.
Yeah. The other one that is complicated, I hate to bring it up, but I think it's important for a lot of people, and that's your recommendation or your observation on surgical wait times. The bottom line was that the set target is not effective for evaluating if the supply has grown enough to reduce surgical wait times.
Yes.
Can you put some meat on
Okay,
that?
so there's a couple of the indicators that we had a fairly significant finding when it comes to wait times, and surgical wait times is one of them. And it's one that has this term, percentage of non-endoscopic surgical services completed or wait times within the benchmark. So if I put that in accounting terms, or terms that I can understand, those are the surgeries that essentially you need an operating room. So it's the bunch that we would typically think of if we're waiting for hip surgery or knee surgery. The concern with that indicator is that the referral period is not included in the calculation of the KPI. And you think of it, that's the period that a lot of us are waiting. So your family physician has referred you, you're waiting to see the surgeon. So that's not in that KPI calculation. The other one where that occurred is the urgent addictions and mental health wait times benchmark. The front end, they call it wait 0, it's described in the report, when you're referred to when you're, you get to have an appointment. That's not included in the KPI, and we recommended in both of those cases that you should be included in that period.
The other thing I was hoping to get a bit of clarity from you on is the idea in the report that there's a lot of different areas that people could go to find health data to measure. There's, you know, there's the dashboard website, there's the surgical wait time website that breaks it down by procedure and provider. Just so I understand this correctly, in your view, should there kind of be one clearinghouse website for all of this, or would it be just as effective if there were at least guideposts on these websites letting people know that there's information elsewhere? Do you have a view on how best that could be organized?
So you've hit on a recommendation that we've made. There is multiple public websites where a lot of this information, KPIs, benchmarks, data, you can go and get pieces, but we recommended that it should be more comprehensive and consolidated. They have actually agreed to this recommendation and are going to look at it. In the report, we also cite a couple of other jurisdictions where it is more easier for the people that live in the province to interpret the results. So yeah, that's a concern because there are so many places to get the information and it's hard to make sense of it all.
Just going back to the primary care wait list, did the changes announced yesterday, does that address all of your concerns with the reporting method?
So there were two components to that first recommendation. I would say it largely addresses the second component. The first component was to explain the changes that took place in the calculation of the KPI back in October of 2024. In the content of what they say, it sounds like maybe they're going to explain those methodologies going forward, the changes, but not necessarily go back to the 2024 changes. So I guess part of it's being addressed. Does that make sense? Yeah.
Yeah,
Okay.
thank you. And then sort of overall, how big of a concern is it to you that we have, billions in spending and the results of that work seem to be unclear to taxpayers?
Yeah. So again, our overriding message is that KPI reporting is a good thing, and a lot of work has been done. We really got an appreciation of how complex of an exercise it is. Like, we actually pulled the data on all these KPIs and some of its multiple sources, data sources. We reperformed the calculation. We did a lot of work just to get, and we really got an appreciation of how challenging it is. So it's very positive that they're doing it, but with the noted improvements that our audit testing has identified, it will improve it going forward.
Was there anything you looked at that dealt with closures of emergency departments? The health department or NSH, I forget which one, every day they issue, on their website which community hospitals, which EDs are closed. But I don't know if there's a place where you can go to see on an annual basis how many hours or days those EDs were down. Is that a key performance indicator you looked at, or what do you know about that issue?
It's not one that we looked at. In the report, there's an appendix at the back of all of I think there's 27 KPIs. We looked at 13 of the 27. It's not one that we looked at, but it could be in the mix there.
The report mentions like a significant gap in the amount of data being received from ERs. What are your kind of concerns with not having that data kind of on the people who are leaving without being treated, how long they're waiting, things like that?
Yeah. So there was gaps in the data. That was the finding. Some zones, for example, the central zone was stronger. In the smaller zones, sometimes it's manual processes that they're dealing with. So it's going to take time to improve on that so that the data across the province is better. Yeah.
Thank you.
Thank you.
Okay. Thank you.